tachycardia. Hypertension and tachycardia occurs more frequent in adults due to their sympathetic response to laryngoscopy. Okay. The response of intubation in respiratory system, such as laryngospasm, resulting in inability to ventilate, and hypoxia. Bronchospasm due to reflex bronchoconstriction occurs in reactive airway disease, COPD, and asthma. Hypoxemia and hypercarbia occurs during prolonged intubation or multiple attempts of intubation. Bronchial intubation due to ETT too deep, causing asymmetrical chest expansion, unilateral breath sound. Intubation also increase the intracranial pressure through sympathetic reflex, through the releases of catecholamines, causing sympathetic stimulation of cardiovascular system, causing hypertension and tachycardia. Okay, now we go on to post-intubation checklist with the mnemonics of A, B, C, O. Airway. First, we have to inflate the ETT cuff. Take note of the ETT depth, anchor at which level, then secure the ETT. Confirm the placement of ETT with direct visualization, 5-point auscultation, chest X-ray, ultrasound, presence of vapor in ETT, and also equal chest rise. Next is breathing. We set the ventilator setting and connect to the ventilator. Obtain an ABG sample 1 hour after and titrate the ventilator setting accordingly. Also check for peak pressure and plateau pressure. In C, circulation, regular monitoring of vital sign, and administer fluids and vasopressor if necessary. Others, such as aspiration precaution, insert nasogastric tube, prop up head of bed 30 degrees, if not contraindicated. Add on analgesia plus minus sedation. For regular eye care and chlorhexidine mouthwash, regular suctioning, and cuff pressure check, maintaining 20 to 30 centimeter water. Next, we move on to peri-intubation hemodynamic collapse. These are the causes. You can easily remember with HOP, hypotension, oxygenation, and pH, which is metabolic acidosis. In hypotension, we have to have at least 2 proximal peripheral IV lines, set for a higher than normal BP, blood pressure before intubating if possible, maintaining a systolic blood pressure more than 140 millimeter mercury. We aim for low sedation and high paralytics. Induction agents such as benzodiazepine and propofol can reduce the patient blood pressure in shock patient by reducing the venous return and also the sympathetic tones. So the induction agent of choice would be ketamine in shock patient, as it gives sympathetic surge and pain control. For paralytic agent, can use scoline or rocuronium. Another option to improve the hemodynamics peri-intubation is push dose of pressor, which is adrenaline. Adrenaline possesses both alpha and beta agonist properties, which increase the cardiac output and causes vasoconstriction, leading to increase of mean arterial pressure. Oxygenation. Option to improve hypoxemia includes the apneic CPAP recruitment method through nasal cannula 15 liters per minute and back valve mask with deep valve 5 to 15 centimeter water with delayed sequence intubation for pre-oxygenation. Through this process, at first we administer 1 mg per kg of IV ketamine, then we pre-oxygenate the patient and administer paralytic agent. Next, we go for apneic oxygenation. which is the passive flow of oxygen in the apnea patient. Then we proceed with the intubation. We try and avoid intubation in this patient if possible. Even consider a short trial of NIV while trying to find and correct the cause of the metabolic acidosis. So the treatment can be bicarbonate therapy or ventilator-assisted pre-oxygenation to ensure CO2 is washed out to prevent further metabolic acidosis and cardiac arrhythmia. Okay, this is a time versus hemoglobin desaturation graph. In a healthy adult following an effective pre-oxygenation, the time for arterial blood to desaturate to 92% may be as long as 8 minutes, as you can see in this graph. For a child, it's reduced to 4 minutes. All these times is reduced in an ill patient who usually unable to achieve a full pre-oxygenation, especially if ventilation is inadequate. You can see in this graph, once the saturation reaches 92%, the rate of desaturation accelerates. Okay, next I will be talking about post-intubation challenges. Consists of inadequate gas exchange, decreased cardiac output, and inadequate anesthesia and sedation. Inadequate gas exchange, indication of poor gas exchange, such as hypoxia, hypercapnia, change in breath sound. Solution is through dopes and dots, which I will mention later. Decreased cardiac output, inadequate cardiac output, leading to cardiovascular collapse, and decreased tissue perfusion of vital organs such as the brain, the kidney. Signs are hypotension, cardiac rhythm changes, skin mottling, and prolonged CRT. Okay, these are the causes of post-intubation hypotension. First is hypovolemia, mainly in shock patient. Treatment, we can give fluid boluses and vasopressor if necessary. Stacked breath or autopip, patient with obstructive lung pathology not completely exhaling prior to next breath, leading to air trapping. This will increase the intrathoracic pressure, leading to reduce of venous return, causing hypotension. Solution, we can disconnect the patient from the ventilator and allow the patient to exhale, or even change the ventilator settings. For tension pneumothorax, you can look for the sign of pneumothorax through the ultrasound, chest X-ray. Solution is neither decompression, proceeded with a chest tube insertion. Mechanical ventilation itself is a positive pressure ventilation which increases the intrathoracic pressure, leading to hypotension. Post-intubation hypoxia. There's two mnemonics, dopes and dots. Dopes helps to diagnose the problem. Displacement of endotracheal tube, obstruction of ETT, patient includes pneumothorax, pulmonary embolism, pulmonary edema, bronchospasm, and collapse. Equipment, referring to ventilators. Stacked breath, reminder about bronchospasm and ventilator settings. About dots, which help us to treat the problem. Disconnect patient from the ventilator. Oxygenate patient with backwater mask and feel for resistance as you back. Check the tube position and function. Did the tube migrated or tube king or even blocked by mucus plug? Adjust the ventilator setting and as sonogram, ultrasound, look for pneumothorax. This displacement of ETT. Description can be ETT can be in the right main stem, oropharynx, esophagus. This can be detected through increase or decreased depth at the ankle level. Unequal breath sound, distended abdomen. Solution is to pull back the ETT or check the ETT placement with a laryngoscope or even re-intubate the patient. Obstruction by mucus plugging, patient is biting. Signs are transmitted upper airway sound, agitation. Solution are can do suctioning and also increase the sedation. In pneumothorax, which is collapsed lungs, signs are decreased breath sound, immediate sternal shift, tracheal deviation. Solution are neither decompression and proceed with a chest tube insertion. Equipment failure, referring to ventilator function or disconnection. It can be detected through the alarm on the ventilator. Solution is to disconnect the patient from the ventilator and manually bagging the patient while finding for the problem and solve the problem. If necessary, to change to new ventilator. Stacking, gas trapping, or auto PIP. Signs are extremely high plateau pressure and peak pressure. Incomplete return to baseline of flow versus time graph. Solution are disconnect and allow the patient for exhale or even adjust ventilator setting, such as reduce tidal volume, reduce the respiratory rate, and inspiratory time. This is the bagging troubleshooting. During bagging, if we heard hissing sound, most likely it's leaking from the ETT. Solution is to re-inflate the ETT balloon or even change to a larger size ETT. If there's a tightness or resistance during bagging, most likely it's an obstructed ETT due to patient biting, tube is kinked or blocked with mucus plug or even bronchospasm. Solution is to increase the sedation or adequate sedation, reposition the ETT, change to a larger ETT or suction ETT if NAP salbutamol and apply obstructive ventilator strategy. If there's an abdominal rise present but chest rise absent, most likely ETT is in esophagus. Then we have to re-intubate the patient. If the right chest rise is present but the left chest rise is absent, ETT is too deep, so we have to pull out the ETT by a few centimeters and re-anchor. If during bagging saturation is not improving, this can be due to the ventilator malfunction. So we have to change to another ventilator or find the problem, the solution. Okay. Now is the ventilator alarms and troubleshooting. Identify the problem. First, we attend the patient's stat. Don't silence the alarm and walk away. Call for help early. Power supply. If there's a faulty to the power supply, we disconnect and reconnect back. Oxygen supply or port. If disconnected or loose, to reconnect. These are the common ventilators alarms that appears, such as AC power loss, apnea, circuit disconnect, high and low airway pressure, high and low exhale tidal volume, high and low minute ventilation, high and low respiratory rate, low FiO2. Ventilator problems showing low FiO2 can be due to disconnected oxygen port or supply, leakage or incomplete insufficient of ETT cuff, or ventilator synchrony. Ventilation parameters such as tidal volume, respiratory rate, minute volume. If it is low, most likely it's disconnected oxygen port or supply, dislodged tube or leaking, wrong or improper setting, such as suboptimal volume not according to ideal body weight. If it's high, can be due to inadequate sedation, patient is in pain, anxiety, wrong or improper setting, example, high volume not according to ideal body weight. High pressure alarm. Always look for the waveform and numbers. Peak pressure or peak inspiratory pressure PIP is the pressure exerted large airways or tube. The normal value is less than 40 centimeter water. And plateau pressure, or resistance in the small airway or lung parenchyma. Normal value is less than 30 centimeter of water. To get this value, we have to press the end expiratory hold icon or button on the ventilator. And auto PEEP, which is breath stacking or dynamic hyperinflation. To get this value, we have to press the end expiratory hold icon or button. This is the two graph. One is the high PIP, no normal B flat. Most likely the ATT is king, patient is biting, bronchospasm, mucus plug or secretion, foreign body aspiration. If the ventilator shows high PIP and high P flat, it can be possible endobronchial intubation, APO, ARDS, pneumothorax, or massive nuclear effusion. Autopip. Causes of autopip can be due to bronchospasm, resistant to airflow, example, kinking of ETT tube, ventilator tubing, or ventilator dysynchrony. Treatment can be pharmacological and non-pharmacological. Pharmacological will be bronchodilators, either inhalational or intravenous. Non-pharmacological through the change of ventilator settings, reduce respiratory rate, tidal volume, increase expiratory time, reduce inspiratory time. Or disconnect the ETT from the circuit and give the patient a gentle chest massage to evacuate the air. Or even increase the ETT size, increase the sedation and paralytic agent. Next is a low pressure alarm appears in ventilator, can be due to disconnected oxygen port or supply, leakage or incomplete insufflation of ETT cuff, or even ETT tube migrated above the vocal cord. Next is regarding inadequate analgesia and also sedation. There are four main types of analgesia and sedation that we use in our ED. It's fentanyl, morphine, mida, and propofol. Fentanyl, the onset time is 1 to 2 minutes, with the infusion rate is 1 to 2 microgram per kg per hour. It acts within the CNS to increase the pain threshold and alter the pain perception. It does not cause as much histamine release as morphine, less likely to cause hypotension as compared to morphine. Morphine onset time is 5 to 10 minutes, infusion rate 2 to 3 mg per hour. It releases histamine causing hypotension, and its active metabolite can accumulate in renal failure. Next is types of sedation. Example, midazolam. Onset time is 2 to 5 minutes. Infusion rate 0.02 to 0.1 mg per kg per hour. It acts on GABA receptor, causing neural inhibition, giving the sedation, induction of sleep, and muscle relaxant properties. Next is propofol. Onset time is 1 to 2 minutes. Infusion rate 5 to 50 microgram per kg per minute. It's a global CNS depression, and this can cause hypotension. Thank you.
All right, thank you, Kar Shen, for your informative presentation. I'd like to open up to our specialists, Dr. Jasmine, Dr. Umar, Dr. Azrin, Dr. Amar, Dr. Shima. If you got any input or you want to question the presenter, or want to add on some more information for us this morning. Thank you.
Hello, good morning everyone. Boleh dengar ke?
Can hear.
Can you hear? Actually quite a good presentation. You covered most of it. The dots, literally whatever we should do lah. Other than that, actually there's mnemonics for post-intubation hypotension from Rebel M lah. If those who have read it, I think you all know, like we use the mnemonic. It's quite a bad word lah. Shit, meaning acidosis, anaphylaxis. H is for heart. It can be a tamponade or anything to do with a thromboembolic event lah. And then your H is your S is tight breath. Then H is your hypovolemia. I is all your induction agent. And T is tension pneumothorax. And E is equipment failure. So literally, actually, you have covered most of it. But most of the time, I understand when the alarm of the ventilator rings, the first thing that we do is we silent the alarm actually.
Yeah.
But I mean, if you silent the alarm and you act to it, it's okay. Not silent the alarm and walk away lah. So most of the time, in our cases, what we see is usually the ETT cuff is either leaking or is it sometimes the ETT is above the vocal cord. And in our COVID patient, I think we have quite a number of patients that end up getting a tension pneumothorax. So the most important thing is to recognize all these issues and develop a solution for it lah. Anyone else got any question from the MO group?
Any questions? There's none in the chat room currently. How about from the floor, from the participants? Specialist input maybe? The specialist input.
Hello, good morning.
Morning, boss.
Okay, good presentation from the group. I think for a lot of the housemen and junior MOs looking at this slide, mungkin they have to have a look again lah. It's quite a detailed presentation. I think you have to just go through a bit personally, each and every one of you, especially if you're unfamiliar with this, to look into the details again. Because dia bunyi macam simple, dots semua benda tu, and the things you want to check, but on the floor, if we don't see it enough, then nanti akan terlupa one or two which might clinically make a difference. So good job for the people, for the group preparing the presentation. For all you other guys yang benda-benda ni seems macam a bit banyak ataupun yang tak berapa familiar, please go through it again and familiarize yourself with these details. Okay.
Any other input?
Assalamualaikum, selamat pagi. Dr. Ikram here. Can everyone hear?
Yeah, can hear.
Okay. I just want to highlight the importance of first pass intubation, especially in patient with the HOP killer, and recently our severe COVID patient with low SpO2. So for this unstable patient, preferably please let the senior one who intubate the patient, so that we didn't risk the patient's life. If more stable patient, then we can allow the junior one to practice. Because first pass intubation is very important. And there's a few techniques that we can apply to achieve that. For example, using assisted video laryngoscope. Also, there's a technique called Buloh, back up and head elevated. This one I usually apply where I put the patient on 30°, 15 to 30° in position and extended the head. You will see a better visualization for intubation. And this technique also improve patient oxygen capacity, the oxygen reserve FRC. Okay, and then reduce the risk of aspiration to the patient. For houseman, if you guys want to try to intubate, please know how to intubate first. Please learn and read about RSI before you try to intubate. Okay, and please assist as much as possible. Then usually we can allow you guys to intubate patient. Okay, for your experience and learning process. All right, thank you.
Right. Thank you, Dr. Ikram, for your input. Dr. Umar? Okay.
Hi, good morning. Good morning, everyone. It was a good presentation. Ikram, tolong tutup kamera. Okay, sorry.
Kenapa tak cakap dari tadi, bang?
Okay, alamak, sidetrack pula. Okay, well, airway assessment is very important. So when before intubating a patient, before intubating a patient, airway assessment is of importance. Kenapa? Because that will reduce errors. And so assess your patient's airway dulu, determine whether it's a difficult airway. Then only you are able to decide what medications, what pre-medication, what sedative agent, and what paralytic agent that you want to use. And when it comes to proper medication use in intubation, and you need to know in and out what medication that you want to use. If you are familiar with midazolam, by all means go ahead, despite the fact that patient is very severely or critically ill. And if you are familiar with that medication, you know in and out, go ahead, by all means proceed. If you're not familiar with ketamine, propofol, intermediate, you don't know how they work. You are not sure what are the complications that may arise after using them, and you have no idea how to manage the complications. Lebih baik jangan pakai. Kan? In obese patients, and if you get someone who are obese and critically ill, assess the airway, perform maneuvers in order to improve visualization of the oral cavity ataupun vocal cord, sama ada buhe ataupun ramp position, and use preferably video laryngoscope to improve your visualization, and try not to use non-depolarizing neuromuscular blockade agent, and preferably use suxametonium, depolarizing neuromuscular blockade agent. Kan? Kalau sekiranya kita tak dapat nak intubate patient, at least you know that patient will come back, patient are able to breathe on their own in a matter of seconds after that. Okay, thank you very much.
Thank you Dr. Umar. Ramai yang tengah tunggu input Dr. Umar sebenarnya tentang ventilator lah. So as we can see in the chat box, actually there's a new mnemonic apparently. So instead of dopes, it's called dopus, and the R in dopus stands for chest wall rigidity, and it's most commonly due to fentanyl. So the treatment is to stop the infusion of fentanyl and to possibly start on naloxone. So this input has been given by Dr. Sonia. If there's no other specialist input, I think we can end our session for today. Thank you, Kar Shen, for your input for today, and then we will continue our next CME next week. There's no announcements for today. Anything will be updated via the group. All right. So thank you. The more night shift, thank you for helping us out, and morning shift, have a good shift, and to the rest, enjoy the day. Thank you.
Thank you.
Thank you, Alex. Thank you, Pakar-pakar, for all the input.
Thank you, everyone.
Thank you.